so what we're going to be doing now is we're going to do a left heart cath on a patient. We're going to do coronary arteries. But we're just going to focus on the lefts right now with this patient because we have looked at the coronaries of the rights, but we just have talked about the catheters to the left. So we're going to do a left coronary angiography on this patient. What catheter do you think I'm going to choose to start with? Judkins what?
4.0.
Judkins left 4 or JL4. Remember, the number tells me the distance between the primary and secondary curve. So the JL4 is what I'm going to choose here. So I have that all selected. I'm going to go in and we're going to try to take these pictures here. Okay? And then discuss the pictures, of course. So here we go. Take my JL. It's going to yell at me because I'm not using a wire because I'm being lazy. To tell you the honest truth, I should use a wire here, but okay. So you notice those dark spots on the screen. You see all these dark spots here?
Yeah.
That's calcification. We normally would not see that. Soft tissue does not show up under x-rays. Remember, it has to be dense tissue like bone and calcium. So this right here, these spots right there that we're seeing, that's the area where calcium has deposited in soft tissue. It looks like the aorta has calcium deposits in it, which means he has some disease and some injury to this aorta. He has some blockages here. And we're going to point out a really cool one here in a second. But I'm going to let you see something. Does this look right to you?
No.
Does that look weird?
Yes.
That's a JL4. Should a JL4 curl up on itself inside the aorta? Have we ever seen that before?
No.
Well, what I'm going to do now is, it looks like the JL4 is not going to work. Okay? Because the JL4, remember, we said the JL4 should just pop into the coronary ostium. This is not going to pop into that coronary ostium. So what I'm going to do is I'm going to take a picture of the aorta and try to figure out, is my aorta too small? Is my aorta dilated? What's going on that my JL4 is acting weird? Okay, so I'm gonna
just inject contrast right in the opening, and it just kind of.
Yeah, I'm just gonna inject contrast. Oh, this is really screwed up. I'm gonna inject contrast right into the distal aorta. Hopefully, if I can get my tip to unfold now. There we go. What are you doing? Oh, it's just, it lost track of where the artery will be. Catheter was. Ooh, she really lost track of the catheter. Let's try that again. It's been overused. I'm going to inject contrast here and just see what's going on with his aorta. Oops, too much. Oh, now I got in. That's not supposed to happen. You don't want it to, it does it. Gosh, this aorta is really weird. They selected a difficult patient, so of course now it's going to be difficult. Okay, here we go.
Oh, interesting.
So what is going on with this aorta?
Is it unfolded?
This is an unfolded aorta. This is what an unfolded aorta looks like. The aorta comes up, over, down, and in. Okay? So this aorta is significantly unfolded. He has actually a couple other problems too. This aorta is significantly unfolded. I'm going to take off some of this stuff here and make it a little bit more easier to see here.
Is that a natural problem, or is it a problem created due to health or whatever?
Yes.
Yes, to walk.
How thick an aorta is in real life.
Okay, so this is the unfolded aorta. It goes up, over, down. And you'll notice my JL4 won't reach that. I mean, it's just too small. Okay, so the unfolded aorta, the JL4 is already bending itself up inside that aorta. It's not going to work. Now, I can make it work. If I spend enough time, I can make that JL4 work, but I'm going to spend a lot of x-ray and a lot of contrast. So oftentimes it's best, once I see that the anatomy is not going to work, it's sometimes best just to get rid of that catheter and put a new one in. It's just going to be a lot easier. I'm going to use less contrast and less x-ray.
Is this something that you can just do visually? You know?
Yeah.
You don't have to do any math or
Nope.
like how long is
Nope.
the aorta?
The aorta should, based upon what we know about unfolded aortas, we know that certain catheters will work best for unfolded aortas.
And that just comes with experience.
It comes with the list that I gave you already.
Well, I mean,
That
You know-
list is based upon our experience in collaboration of all the experiences of unfolded aortas throughout history that we've done. So, first of all, before we go on, this isn't a great picture. Let me see if I can get a. I'm going to have to pull up a little bit here. I'm going to get a better picture of something here. Yeah, there we go. As you can see, the Judkins left is now totally folded up in the aorta. Not a good situation. Okay. I'm not getting the picture I want. There we go. This should do it. A lot of contrast here. Okay. What is this first artery right here? Brachiocephalic, also known as the
innominate.
innominate. The innominate branches off to what artery here?
Subclavian.
Right subclavian. And what artery? You can't really see it. It didn't fill really well. What artery right there?
Carotid.
Left common carotid. Right common carotid. This artery, because of how I have it turned, it looks like it's coming off right at the same one, but it's just a little bit over. What's the next artery that comes here? Left common carotid. And what is this one right here?
Subclavian, the left.
Left subclavian. Very good. And usually they're right on a tight curve. Okay, they're usually innominate, left common carotid, right subclavian. But this is unfolded now, so they're spread out, and it looks just very strange. So my JL4 will not work. So let's take that out. I could make it work. It's going to be a lot of contrast and X-ray to get it to work. What catheter should I select for an unfolded aorta? Nope. I could technically do it. That's going to take me a long time, though.
XVR?
No. First, no.
It's a JR6.
No. We're on the left side.
A JL6.
JL6. That is correct. A JL5 is used for a dilated aorta. This is not dilated. Means it still has the normal curve, but it's just
Swollen.
fatter and swollen. This is an unfolded aorta. So this is a JL6. So I'm going to choose that here. Okay. Now we're going to see if this works any better. Guess what? It went right in. Or pretty close, I think it's pretty close to being right in.
Did you say that, the AL, like, there's an AL that goes in as well?
It could, but we always start with the top of the list and work our way down. An
Okay.
AL2. So this is a JL6, and it worked perfectly. It popped right into place. Remember what Judkins said. My catheters, if selected properly, will work unless operator error, unless impeded by the operator. And so the JL4 was stopping and folding up on itself way back here. It was not going to be long enough. So remember, the number is the distance between the primary and secondary curves. So the JL4 was down here and it was folding it up on itself because the aorta was just too big. JL5 would have been right here. JL6 gets us right into that ostium and connects us right where we need to be. Okay? So this is why we want to know that list. So when we see an unfolded aorta, and this is what an unfolded aorta looks like, when we see an unfolded aorta, we can say, I need to go with X catheter. Okay? The doctor could force it. The doctor could make a JL4 work in this case.
You did it.
I did it, but it took me a lot of maneuvering, a lot of manipulating, a lot more X-ray. This just
Yeah.
went right in. I didn't have to even maneuver it at all. So oftentimes you'll see doctors are struggling with a catheter, and it's like, if you just switch to a different catheter, we would have decreased the X-ray dose significantly, and contrast, because every time the doctor thinks that he or she is close enough to that ostium, they will inject, and that's just, if you're not in, you have to keep fighting and fighting and fighting. So now I use a JL6, okay? So now I'm in. I had an unfolded aorta. If you notice, it looks quite a bit the same here, this long arch. The arch is prolonged. So now let's take a look at these arteries, and let's try to name them, but more specifically, let's try to name what they feed, because that's your favorite thing to name, right?
Yes.
Not everybody is agreeing with you. There was silence. When you said yes, I could feel the silence of people like, what is wrong with you?
I can feel the distance.
Take a deep breath in and hold it. Don't breathe, don't move. It's too far over. His heart is really large. Let's try that again. Take a deep breath in. Don't breathe, don't move. Okay. So here we are. Because I hate touch screens so much. We're going to start with Stacy. Stacy,
Yes.
what do these arteries feed?
Anterior lateral.
What artery is that?
LAD, or those are the diagonals.
Those are diagonals, that's correct. So anterior lateral wall, very good. Agar, what does this artery feed?
This is obtuse marginal.
Very good. So what does it feed? I'm sorry? Actually, you were right. Posterior lateral wall. Very good. Okay. Next, Kim. What does this artery feed?
It feeds the left atria, the left posterior lateral ventricle.
Okay, very good. And in some patients, what does it feed?
It can also feed the diaphragmatic apex.
Does it on this patient?
It does not.
Does not, that's right, it does not. We would see a
The curve.
curve right here going towards the LAD. It'd be more dramatic. And so no. So what dominance should this patient be?
Right.
It should be right dominance, okay. Dosha, what do these arteries feed?
The septums,
What, yep,
they feed the septum,
what part of the septum?
the anterior.
That's right. You don't have to say anything else, it's just the anterior
Anterior
septum.
septum.
But it's best to say interventricular septum, because you have two septa.
Yeah.
You have the atria and the ventricle. And
Ventricle.
the atria septum is fed by the atrial branches. 'Cause
Branches.
they're just small branches. They don't require a lot of blood. But the interventricular septum, the anterior interventricular septum. Okay. Stephanie, what does this artery feed?
Feeds the anterior, posterior, lateral, of the left ventricle.
Okay, you're close. It's the anterior, but not the posterior. The posterior is fed by the circumflex.
Okay, so
So it's
anterior
anterior
and
and-
lateral.
Anterior, anterolateral, and
That,
septum.
Septum.
Anterior septum. Okay. So the anterior, because it goes down the anterior wall, the anterior lateral wall because of the diagonals, and the anterior septal
Goes
walls
into the
because of the septum.
Okay.
Okay. Does that make sense to everybody? Okay. And last but not least, Vanessa. What does this feed? Left ventricle. What parts of the left ventricle?
Anterior, posterior,
And the left
the left.
atrium. That's right. And in some patients, what does it also feed? Diaphragmatic wall. By the way, while we're on that, what percentage of people have the circumflex by itself feeding the diaphragmatic wall? 12%. Very good. What percent has only the right feeding the diaphragmatic wall? 86%. Very good. And how many times do both the right coronary and the circumflex feed the diaphragmatic?
2%.
2%. Very good. Okay. Let's look at these another way.
It's got a block. One.
Where at? Where do you see the blockage?
LED.
Where at in the LED?
Proximal.
Proximal LED. Does everyone agree with that?
Yes.
Yeah, take some of this off.
You said he had a lot of problems, so.
He has a lot of
I
problems,
think that
but-
There's,
Yeah,
I've seen those
right
signs.
here. Now I want you to pay attention to this. Does it look too bad right there?
It does look bad.
It looks pretty. It's pretty thin, right? Pay attention to that though, okay? Let's take a look at this image here. Oops, sorry. Okay. What do you notice about the left main? Does it come off as it normally should?
Is it long?
It's long, but it also does something very interesting. It goes up
Up
and then down.
Superior.
So not only does he have an unfolded aorta, he also has a superior offtake because of that unfolded aorta. Where the left main goes up before it goes down. Remember, the left main should go out and then down, but this person's left main goes up and then down, making it a superior offtake. So this person has a lot of weird anomalies. He has an unfolded aorta, and his left main goes up and then down. JL4 had no shot of hitting this. It's just not designed to do that. It'd be very difficult to get the JL4 to do that. Even though I did it, it was by accident. Okay. So, let's start at the back and work our way up. Vanessa, what does this artery feed? Okay, left anterior and left anterior septum of the ventricles of the left ventricle. Very good. Stephanie, you're next. What do these arteries feed?
Those are diagonals, maybe the interior wall.
Very good. Okay. Tosha, what does this artery feed?
That's left main, so it feeds the left ventricle and left atria, the left anterior, posterior, lateral wall of the left ventricle, and also sometimes the diaphragmatic wall.
That's right, diaphragmatic wall. It's a great word. It's a great scrambled word. Left main is responsible for all of that. Luckily, in a few of us, it feeds the diaphragmatic wall, not in all of us. Kim, what does this artery feed?
It feeds the left atria, and it feeds the posterior lateral left ventricle,
Very good.
and
Occasionally.
it'll feed the diaphragmatic apical portion of the left ventricle.
Very good. Okay. Agar, what do these small arteries over here feed? It's harder to see them in this view, but do they feed? That's right. And so what does it feed? That's right, the anterior ventricular septal wall. Very good. And last but not least, Stacy, what artery does this feed? Or what artery? What wall does this artery feed?
Is that obtuse marginal?
It's an obtuse marginal.
So it feeds the posterior lateral of the left ventricle.
Very good. And again, we see the little tightness right there again. Do we see it as well as we did in the last image?
No, and I wouldn't have even picked
Nope.
it up on
And
this.
that's why we look at different views, because now it's overlap. Because the artery looks like it's going straight down, but what it's actually doing is coming out a little bit and then going straight down. And so it's hiding itself. It doesn't look as bad as it did in the last view.
And
Okay.
that obtuse marginal seems thinner at the top
Yep.
than at the bottom. Is that
There
the
is a
same
little,
situation?
yep, there's a little bit of a narrowing there that we didn't
Oh.
see in the last view.
Okay.
Okay. So let's see another view here.
I mean, that was a lot. It wasn't just one little section. It was
A large
down
section?
the,
Yeah.
I don't think I've seen that before.
Okay, let's take another picture here. Okay,
Oh.
so this is our next view.
That is a
Yeah, we
blockage,
see
yeah.
the
Now it is there.
thinning of this, what you were saying earlier. Is
Right
that-
there,
yeah.
it looks a lot thinner here, doesn't it? We didn't see that in the first image because of the overlap and how the artery was coming towards us. This is why we need orthogonal views. Okay, we need different views so that we can see all sides of the vessels and in different alignments to the X-ray beam. Remember, the best way to see an artery is when it's 90 degrees or when it's perpendicular to the X-ray beam. So the X-ray beam is going this direction, and my artery is going in this direction. That's when we'll see it the best. Okay. But if my artery is like this or straight on, we're not going to see it as clearly. Okay, so let's go around. Let's have fun here. Let's start in the middle. Kim, what are these arteries here?
Septal perforators.
And what do they feed?
The interventricular septum,
What part of it?
the anterior.
Very good. Agar, what did you just sign for me? Agar, what are these over here?
These are the septals.
Nope, these are the septums down here, so what are these? So what artery are they coming off of?
LED.
That's right, they're coming off the LAD. So if they're not septals, what would they be?
Oh. Diagonal.
Diagonals, very good. And what does the diagonal feed?
I'll say anterior.
Anterior, what?
It's not lateral.
Yeah, it is actually. It is anterior lateral. Okay, diagonals feed the anterior lateral wall of the left ventricle. Stacy, what is this artery here?
That's the left main.
What does it feed?
It feeds the anterior lateral, posterior lateral, posterior, left atria, and sometimes the diaphragmatic wall. One last.
Okay.
I think that's it, right?
Okay. Of which side though?
Oh, left side.
Of the left side, very good, okay. Vanessa. What is this artery here? And what does it feed? Posterolateral version of the left ventricle, very good, okay? And there is a diagonal here, but it's overlapped, so that's what this funny thing is here. It's actually diagonal, obtuse marginal, that's overlapped. But here you can see how the left main goes up before it goes down. So this is what we mean by superior. It goes up, down. Can we see the blockage here in the LAD that we saw before?
Yes.
Mhm.
No.
Barely, it's overlapped, isn't it? It's overlapped, but we can see the circumflex pretty good in this one. Okay. Two more images. Okay. Here's our next image, or third image, or fourth image. Okay, so now, same thing again. Dosha, we're going to start with you. What are these arteries?
The outside or inside?
This one here and this one here.
Those are diagonals.
And what do they feed?
They feed the anterior lateral wall of the left ventricle.
Anterior lateral wall of left ventricle. And this looks like it's on the inside, but that's deceiving. It's actually on the outside. It's just overlap. Okay. Stephanie, what does this feed?
That is an, it's like an obtuse marginal.
Very good.
It feeds the posterior lateral wall of the left ventricle.
Very good. It's the posterior lateral wall of the left ventricle. Big. This is probably the best view we've had of that obtuse marginal, seeing how huge that is. Okay. Vanessa. What are these? And what do they feed? Very good. Okay. Stacy. What is this little one back here?
Is that the atrial circum?
And what does that feed?
The left atrium.
The left atrium. Very good. Agar, what are, or what is, I can't remember what I've asked already. What is this artery right here?
LED,
LED, and what does it feed?
anterior lateral and anterior ventricular system.
Yes, very good. Absolutely. The anterior wall and anterior intraventricular septum. Very good. One last picture, and I'm going to want you to pay attention to the proximal LED in this picture, okay?
The obtuse marginal looks like it's coming really close to the apex, but then never feeds the apex.
Nope, it doesn't go past. And actually, that's looks that way because it's looking like it's going down, but in this view, it's actually wrapping away, and then this is actually coming towards you a little bit. So it's actually coming in this direction, not this direction. In 3 dimensions again, it looks like it's going straight down. It's actually curving out and around towards you. It's a little bit of a deception. Oops, too much.
Oh, I see the calcifications that you were talking about earlier. Is that the goes in the middle?
Yes. See that little thing right that's still there? Okay, now. What do you think about the tightness in this view?
It doesn't look as tight, but is that due to overlap?
It actually, if you come close, you can see it actually narrows down to a point right here and then picks back up. It actually narrows down to that point. It cuts in really deep here and it cuts in really deep here. So actually in this view, it looks like it narrows down to a cone and then opens back up again. So in this view, it actually looks, you can actually see a circle right here, almost a ring around the vessel. Can you see that? It might be difficult from way back there, but there's a tiny little ring around the vessel right here that's almost totally blocked off. So in this view, it shows that it is much worse. If I back off a little bit, I can actually make it look even worse. I can see. A little bit more. That's not it. where it can make it look really, really significant. Oops, I almost had it, I stopped at the wrong place.
Oh, yeah.
Oh, yes.
You can see how really narrowed
Mm.
it is right there. So again, that's why we want to look at different views, and the circumflex also is pretty narrowed in this view. So this gives us, this patient I love because one, it shows us the need to have different catheters. This patient had two things wrong with them that made it difficult for me to use a JL4. First of all, they had an unfolded aorta, where the aorta didn't have the natural curve, which is what the JL4 is designed for. And it has a superior takeoff of the left main, which is not what the JL4 is designed for, okay? So I could have sat here and monkeyed around with the JL4 and maybe have gotten it in, maybe have gotten it in place, but all that time would have been lost, and X-ray dose would have been increased, contrast dose would have been increased when I simply changed out for a JL6 and it just went right back in, and I didn't have to manipulate or take any more X-rays than I absolutely had to. Okay. By the way, what view am I in on this? Eleocaudal. That's good. That's correct. Eleocaudal, also known as the
Spider view.
spider view. Now there is one thing I want to point out. If I'm going to take off my catheter, I'm going to show you something here that we normally cannot see. So I'm going to show you something that we're not supposed to be able to see at all. And on this patient, we can, and it's not a good thing. So, you see this right here?
Mm-hmm.
I'm going to give you a hint. We should not see that. What shape is it? It's circular. Okay, I'm gonna monkey around with it a little bit more. A little bit off that. There we go. That's a good picture of it. Does anyone have a guess of what that is? If I put my catheter in, it might help you understand where it's at.
Wait, could it be a valve?
It is the valve. Hold on a second.
There's calcification around the valve.
Yeah, absolutely.
Oh, no.
So, let me remind you where my left coronary artery is. Oops. I'm in the wrong view here. That's the right coronary artery. There we go. So my left coronary artery is right there. So where's my left coronary artery right above? What valve? My left coronary artery comes off right above what valve?
Aortic?
The aortic valve. So I'm in the aortic sinus of Valsalva. This is my aortic valve.
Oh.
Soft tissue is not supposed to be absorbed, it's not supposed to absorb X-rays. So what has happened here is this has a heavily calcified aortic valve, which means it is stenotic. It's not working properly. Okay. Matter of fact, the cool thing about this valve is I can see 3 leaflets. 1, 2, 3 leaflets. So what is the circle around the valve called? What am I seeing here?
And you.
The annulus, that's right. And where the valves come together, those are also calcified. What are those spots called? The commissures. So this whole thing is stenotic. Now the other thing I want you to notice is there's the Wigger's diagram right here, or at least a part of the Wigger's diagram. What pressure waveform is this right now? The arterial. Arterial. Because I have diastolic, systolic, and what is this point called? The closure of the valve, what's it called? Incisura or
The
dicrotic notch. I'm going to try to cross the aortic valve here. Where is my wire? I'm gonna try to cross the aortic valve. I need my wire. Where's my wire to cross the aortic valve? None of these will work. Four. Incisura. Oh, there it is, right there. Okay, so I'm gonna try to cross that valve. Let's see how lucky I get.
Look at that.
Oh, wait.
So they're going across. Let's try to get a new device.
Okay.
So I'm gonna put a straight wire in. Which is gonna get caught on a catheter. What am I
Sitting
doing?
on the building.
There we go. Wire, here comes my catheter. So I'm gonna try to go across that valve here. This one, oh, got right. Was it across it for a second?
Is that what you call damping?
There, it's damping.
No.
It did not like it. No, that's okay. I'm just gonna go across that valve. I don't have to do anything. Oops, that's not the patient I wanted. Give me a second. I'll reload that patient.
This thing's got a mind of its own.
It does sometimes. I think it's funny.
Have worse vertigo if you watch this.
What was that?
She's trying to set her phone and she's got it falling off of stuff and it's all jiggly, I said, oh
Oh,
gosh,
yeah, that'll
don't
give
watch
me-
that.
Look at you. Okay, here we go. Let's try this again. So here's my guiding wire going up, which will help my catheter stay straight. You notice it's nice and straight, it doesn't have its curve. So now I'm gonna try to get it across that valve right there. There we go, across the valve. I'm in my left ventricle. So there's my left ventricular pressure. Okay, so I'm in the LV. So I have a systolic and diastolic and diastolic, also known as end-systolic right there. Okay. Now, when I pull across the valve, according to the Wigner's diagram, on either side of that valve, the systolic pressure between the LV and the aorta should do what? If I pull across that valve, the LV pressure, systolic pressure, and the aortic systolic pressures should be what? The same. They should match. Because remember, the valve opens during systole, so the ventricle and the aorta during systole, across that aortic valve should match, because that's when the valve is open. So I'm going to put this here to show you where my systolic pressure is right now. And Stephanie, come up here. I'm going to have you pull it across. When I tell you, but can you kick me the pedals? Just kick them over. Okay. When I tell you, I'm just going to have you hold on to the hub with your right hand. your left hand, sorry, your other right hand. Your left hand, and pull out the catheter when I tell you to, okay? So again, just as a reminder, this is where my systolic pressure is now. So go ahead and pull it across. Are they equal?
No.
No.
I'm pulling it all the way out?
Yep. The aortic pressure is significantly lower than my ventricular systolic pressures.
Oh, yeah.
That is a sign of stenosis. The valve is not opening it up all the way, so the pressures can't equalize. So this patient has lots of problems. He has two blockages, one in the LAD, which is really tight, one in the circumflex. He has an unfolded aorta, which is just an anatomic anomaly. He has a superior offtake of the left main, which is just an anatomic abnormality. Doesn't cause anything harmful. And he has aortic stenosis that we can see on the screen, and we can measure using Wigger's diagram or the hemodynamic testing. Okay, so it's not just what we see on the picture. We also have to pay attention to what's happening hemodynamically, because that will also tell us that this patient has a pathology that we were not expecting, which was the aortic valve disease. Okay, that is good enough for the left hearts. The next thing, or not the left hearts, the left coronaries. So the next thing we have to do is we take out that left coronary catheter. What do we have to still do?
Check out the right.
We have to check out the right coronary arteries. And so the right coronary artery catheters, there are a lot more than the left. Okay? There are a lot more catheters for the right coronary artery than there are for the left. And again, here are the images that we will be talking about. So we've talked about the lefts, the extra backup, the JL Judkins left catheters, the Amplatz left catheters, the multi-purpose, the extra backup. Now we've got to talk about the right catheters, okay? So the first catheter that we choose, because this doctor that we start with in 90% of our cases, and we start with this one because, well, this doctor did their research. They were really good and they did plenty of studies. And that is the Judkins right catheter, also known as the JR. Also known as an FR because Judkins right is a copyrighted name. Now the Judkins right catheter, just like the Judkins left catheter, comes in a 3.5, 4, 4.0, 4.5, 5, 5.5, and a 6 shape.
There's a 4 and a 4.0.
Oh, sorry. Okay. But they don't look like Judkins lefts. This is a Judkins right. Okay. Doesn't look anything like a Judkins left. Remember, a Judkins left had this neat little almost J design on the tip of it. This is a Judkins left. The Judkins right does not have that. The sizing of a Judkins right is still the same. It is the distance between the primary and secondary curve is what makes this one in particular a 5. Okay. This is a Judkins right 4. And if we get these curves to match up, you'll notice that the Judkins left 4 is shorter than the Judkins left 5. So here's the Judkins left 5. Here's the Judkins left 4. The distance between the primary and secondary curve is what makes this a Judkins 4. Dr. Judkins found that a Judkins 4 will work in about 90% of your patients. Just like a Judkins left 4, a Judkins right 4, still about 4 centimeters from the aortic arch to the right coronary ostium. Now, the Judkins catheter allows us to see something that we don't see on left catheters very often. I hate when I put something down and I lose it. Oh, it's right here. Okay. So if we look at a Judkins left, you notice it goes pretty much straight up, secondary curve, primary curve. It goes straight up, secondary, primary. But with the Judkins right, you notice that there is a curve here. 1, 2, 3. Almost all right coronary catheters have a tertiary curve. And you notice that the tertiary curve comes in the body of it. It's not towards the tip. The tertiary curve comes in the body. The Judkins left is straight, and the rights have this tertiary curve. And there is a reason for that. Remember we said that catheters, when they go up the aorta, will want to go across and keep up, or keep right next to this anterior wall here, or superior wall here. And that means the catheter is going to want to face towards the left coronary artery. They're going to come up around this, and that tip is going to point away. So what this tertiary curve does, if I get this positioned correctly, there we go. Good grief. Now let's go deep in there. Fine. I'll let you do what you want to do. It wasn't fighting me this bad this morning. There we go. So if you notice, it comes up, it follows that outer wall, but then it dives in. That tertiary curve forces it to dive into that inferior wall. So it follows that outer wall like catheters would, but that tertiary curve causes it to dive into this curve. The secondary curve then curves it back out around to my ostium, and then the tip goes into the ostium. Okay.
The tip is going through first, so wouldn't that hit that whole outside before it even makes that proper turn?
Not really, because this distal tip has force on it, so it's forcing that catheter to go against this back wall. So even as it's going up the aorta, it's forcing that catheter to go against this back wall. So as it's turning, it's still forcing it against this wall as it goes down. So even though it's further down from the tip, this catheter, this force of this curve is forcing that proximal tip over to this side as it goes down the ascending aorta. And then it pops in. So that's why we say that the tertiary curve is for positioning. It positions the catheter away from the superior wall of the aorta so that the secondary curve can provide backup and hold it against this distal wall. Why aren't you staying there?
So it's not the superior, you're saying it forces it around the distal wall or the inferior wall?
It forces it off the superior wall to the inferior wall. Okay? This is like going way deep seating. There we go, that's better. So it forces it off. The superior wall goes down, hits the inferior wall. Then we have backup here from the secondary curve. And then the primary curve sits right there and stabilizes it in the ostium. Okay? So we don't see this tertiary curve up here in left catheters because we don't need it. Okay? We just need somehow to get this catheter off of this superior wall and face in the right direction. JL4 is the one that is most often used. Now, like the JL4 or the JL5 or the JL6, this gives us excellent backup, but how much of the tip actually goes into the ostium?
A little bit.
Very little. So what happens to the stability?
It's not much.
It's not much. Remember, stability is the ability to keep in the ostium. The backup keeps my catheter from backing out when I'm injecting, but the primary tip is to keep me stable into that ostium. And since my primary tip is so small, or the proximal tip is so small, the stability of that catheter staying into that ostium is not great. It has good backup, just like the JL4 said. We have good backup, but the stability is not the best. But it is the easiest to get in. Okay, so it might not be the best catheter, but it's the easiest to get in, which is why we like to use it. Simplicity sometimes beats out extravagance. So you're going to see a lot of curves that are extravagant, but we like simplicity sometimes. So what if we need more backup? Well, if we need more backup, we can go and, just like the lefts, we have a doctor by the name of Amplats. Dr. Amplats creates an Amplats right catheter.
Are there other names?
2.3, is that what it is?
2.5. Does that look like a 3?
Yes.
How does that look like?
Looks like a 3.
2.5. There you go. It does
Okay.
look like a 3. I didn't put my little head on it, did I? Okay. 2.5, 3. Now, Amplats, we've heard him before, right? Where did we hear Amplats before?
In the left.
Aflax, that's right. So we look at what? We look at the tip, we look for a
Duckbill.
duck head.
Oh, that's a small duck.
Okay. So the biggest problem that we have is, first of all, Amplats rights have a tertiary curve, and you can see it. So we have this, again, that slight curve to the outside. Okay? If we look at an Amplats left, where's my Amplats left? Oh, here we go. If we look at my Amplats left, we don't have that tertiary curve. It's pretty much straight up and down. Or if we look at the Amplats right, we see this tertiary curve again. Okay. Also, people ask, how can I tell between an Amplats left and an Amplats right other than that tertiary curve? Look at the size of the duck heads. These are both 2s.
One is thick.
It's not just thick. Bigger, much bigger. Okay.
The left one?
The left one is much bigger.
So we're not measuring by diameter anymore.
No, it's just, well, we are, but remember, it's a relative diameter. This is twice as much as a Amplats 1, which is why it's called an Amplats 2. Okay, so it's not an exact measurement. Remember, Amplats is talking about the diameter, but it's not an exact measurement. It's a reference measurement. So this is what I tell people. If you see an Amplats catheter and it has a daddy or mommy duck head size, it is a left Amplats. If it has a little baby or a little one duck head size, it is a right Amplats. Okay? So small duck head is right Amplats. Big duck head is left Amplats. Okay? So the right Amplatses are always smaller. Even if they have the same number, the right Amplats will be smaller than the left Amplats will be. And so people say, well, why is it smaller? Why can't we just use the same one? I mean, they're kind of designed the same. Well, as we come around here, again, we get in there. Oops, too far in. Because of how it comes off of the aortic arch, it can't fit the entire, we can't have a huge head down here because it's already favoring the side of the right coronary artery. So if I had too big of a head, it wouldn't line up. It wouldn't go into the ostium. Okay, if the head was too big, it wouldn't go into the ostium. I have to have a smaller head to fit into the aortic root and still fit into my right ostium. Okay, so the Amplats rights are always going to be smaller duck heads than the Amplats left. And that's because otherwise, if the head is too big, it wouldn't line up right. Because if the Amplats left, it just would be too big. Okay, so that's the Amplats right catheter. The good thing about Amplats right catheter is you can see with this one, it goes pretty deep into the ostium. So it has really good support. Backup, it's not as good as a backup as the Amplats left because it doesn't fill up the entire aorta. It only fills up half the aorta. So the backup on the Amplatz right is not as good as it is with the Amplatz left, but the support of it, that distal tip, the support, keeping it in place, is much better on the Amplatz right than the Judkins right. So why don't we use the Amplatz right more then, if it gives us better support and an okay backup?
Flexibility?
It's not so much flexibility. This is about as flexible as the JL, or as the JR is. It's not JR. I'm losing my cap, but yeah, they're about, what was that?
Harder to maneuver?
It's harder to position, because I have to get this into the aortic valve. Okay, so it's harder to position. So again, the JR4 isn't necessarily better than this catheter. This catheter actually has some benefits that the JR4 doesn't give us. It gives us better support because it has a longer distal tip and pretty good backup, whereas the JR4 just gives us backup. But the reason we use the JR4 is because it is simple. It is easy to use in position. Very simple. So what if the Judkins right and the Amplatz right don't work? Well, then we can get creative. And one of the options we have is something called a hockey stick. I didn't name this, and no Canadian named this.
It doesn't look like a hockey stick, does it?
So this is the hockey stick, and I have one here to show you. This is a hockey stick. Now, I have never played hockey, but have you ever seen a hockey stick look like this?
No.
You just call it what Captain
Okay. I don't know. Whoever named this obviously had never touched a hockey stick in their life.
It's closer to a fishing hook.
Yes, well, but there's one that's even closer than that. I'll show you that in a second. So they couldn't call it that. But so they said, oh, this looks like a hockey stick. And I can't see where they get hockey stick out of this. The multi-purpose A, to me, it looks like a hockey stick.
Yeah.
This is not a hockey stick, but it is called the hockey stick. Like I said, no Canadian was used in making this catheter. Okay.
I was looking at this slide last night, and it looks like there's 2 amplets left too. So that one right there, and there's another one up above that are both amplets left too.
This should be Amplatz right too.
Okay, that's what I thought.
That should be an AR2. That was
Okay,
just
just-
copy and pasted.
Okay.
Okay, so this is a hockey stick. Okay, so a hockey stick doesn't have a tertiary curve, even though it looks like it does. It kind of has. So we have this curve right here, which is technically the secondary curve. This right here is technically the primary curve. I don't have any curve at the tip like the other ones have. So even though I have a positioning curve, this would still be called its secondary curve, even though it's used for positioning. If you notice, all right catheters have this curve right here to get me off of that aorta down and around. Okay, so they all have this strange curve. But on the hockey stick, it's not called the tertiary curve because the hockey stick wants to be different and not look like a hockey stick. So how do we use this one? Well, this looks like almost an Amplatz, doesn't it? It
Yes.
almost looks like an Amplatz. What is it missing?
The beak.
It's missing the beak. I like that. The distal tip. So what the idea of this is we just, because that beak makes an Amplatz hard to position, what we do is we put this in and we just drag this up and down. And as you can see, watch my fingers. If I drag this up and down, what does it do?
It just hooks up.
It just hooks up into there. It has good stability. Does it have any backup whatsoever?
No.
No backup, but it has pretty good stability. It hooks in there, just like that. Boom. See that? So, because it doesn't have any backup, it's not as good as a Judkins right or an Amplatz right. It doesn't have any backup. But it's easier for this to place than the Amplatz right. So if a doctor says, hey, the Judkins right isn't working, the Amplatz right is going to be a pain in the butt to place, they might go for a hockey stick. Most doctors will still look at Amplatz right first, but hockey stick, it's like an Amplatz right, except it doesn't have that beak on it. The idea is you're just trying to hook it.
Does it just have the one size?
There's actually a couple sizes. It's a 1 or a 2,
Okay.
and most of the time we use a 1. Okay.
The
And-
Amplatz was what size?
Two.
Two,
Yep.
sorry.
Anything that's circled is what we usually use.
So even for this one, it is the distance between the,
No, it is just the
Just one
design
and two?
the design of the angle. Yeah, it's the amount of curve this has. There's the first curve and the second curve. So one's really tight, one's less tight. Okay. I don't have a BR or a BRAT, what we call a BR or a BRAT, backup right artery catheter. This looks like what we call a shepherd's crook. Okay, so if you look at here, it looks like a shepherd's crook. It looks like if you took an Amplatz and instead of going like this, you turn it on its side, okay? So again, the Amplatz would be like this. Here's my beak, and here's my curve. So instead of being like this, I just take that Amplatz and kind of put it on its side, okay? So it looks like a shepherd's crook.
question mark.
Or a question mark, yeah. It does have three curves. It has a little head here like the Amplatz does. 1, 2, and it also has that weird tertiary curve on it, 3 as well.
ART.
It's called the BR. Sometimes it's called the BRAT or the BRAT or the ART. So it's the backup right. So it's the backup right. Sometimes also known as an all right. ART means all right.
All right.
Or a BRAT, backup right,
Oh.
artery, takeoff, I can't remember, BRAT. But it's usually BR or ART. So all right, ART, or a backup right, BR. The backup right has the same numbers as Judkins without the halves. So back right, upright has a 4, 5, and 6. And it's the distance between the primary and the secondary curve again. So how can I tell the difference between a hockey stick and a backup right? The hockey stick doesn't look like a hockey stick. Backup right looks like a shepherd's hook. Okay, the backup right looks like a shepherd's hook. Okay. And then you get to a doctor who says, oh, these aren't working. Okay. Most of the time, we will go in this order. Judkins is the first thing we try. Amplatz is the second thing we try. Some doctors want to stay away from hockey sticks or extra backups unless they're doing an intervention. So where do we go next? Well, there's something called a progressive right. And progressive rights, there is no numbers. There's just one type of progressive right. And these were really popular for a long time. A progressive right just has a positioning curve and a sharp distal curve. Okay. It doesn't have any sweeping curve. It doesn't. This has almost no backup and no stability.
Why
What
were they popular?
was that?
I can't imagine why they were popular.
Well, they were popular because, like the shepherd's hook, or like the hockey stick that we were using, that distal curve was so sharp that as you're pulling it up, it will hook into it, but it won't go deep into it. So it helps us find the coronary artery really fast. It's not designed to stay in place. This catheter is designed just to find the ostium and take a picture and get out. Okay? Because once you start taking that picture, it'll back out. But if nothing else is lining up, this thing you can just go up and down. There's not a lot of real dramatic curves that could damage the artery. You just drag this up and down the artery until it pops in. The problem is it's not going to stay there very well. This is only used for diagnostic procedures. And doctors liked it because it's really easy to use. You just popped it down. It didn't have any of these great curves you had to worry about. You just slid it up and down until hopefully it popped into something. Okay. And doctors are like, hey, that's great. Unless you want to do an angioplasty. Now, you can't use this for an angioplasty. The benefit of using one of these catheters is if one of those catheters works, guess what angioplasty catheter I will use? The same one. But with the progressive right, if this works and it takes a picture, I don't know which catheter to use for the angioplasty. So for the longest time, the progressive right was used a lot. Doctors were like, don't give me a JR4, give me the progressive right, because I will find that right coronary really fast. I'll just, no contrast, I'll just go up and down, all of a sudden you'll see it hook in, you're like, okay, I'm in, and take a picture. But you can't do an angioplasty with it. So the problem is if you find a blockage in the right and you use your progressive right, you really don't know what catheter you should use to fix the vessel. So it's good for angiography, it's not good for anything else. Okay? So it's kind of lost fashion. It was really big for a while. When it first came out, doctors were like, oh, this is awesome, it's so easy to use. It's easier to use than the JR4 even, and you know, I know I'm in, and I can just, there's no 1, 2s, or 3s I have to worry about. It's just one catheter and just drag it up and down until they get a picture of a right, and they're like, oh, there's the blockage.
Now what?
And yeah, now what catheter do I want to use? I don't have any trial or error before this. So progressive right, if we're doing a diagnostic, a doctor will jump right to the progressive right if amplats or JLs won't work, or JRs won't work. But it's gonna hurt us in the long run. Now the final two, Williams rights are very expensive, so I don't have one. But William rights, also known as 3DRs, are one of my favorite catheters in the world. A 3DR looks exactly like a Judkins right catheter. They look exactly the same. You're making, and I know what you're thinking, if they're exactly the same, why do we have a different catheter, right?
Maybe it holds form better for a longer period of time.
It does hold form better, but in a different way, because you see, the catheter looks exactly the same that way, but it has a third dimension to it. It bulges out sideways a little bit.
So it's like 4 curves?
Was that?
There's 4 curves then? Or no?
It has, actually, technically we still call it 3 because this is part of the third curve, but it doesn't just bend out, in, around, and here. It looks exactly the same in this direction, but when you turn it, it has a 3-dimension curve to it. That's why it's called the 3DR. And you might say, why is this there? If my ostium is more anterior or posterior, a normal JR4, which is designed to come off the wall and point in this direction, won't be able to hit an anterior hole. You see, it's too far back. I can spin this.
You would twist the hub? to
Yeah,
get it?
yeah. When I twist the hub, I will spin this, but it won't ever reach. Okay. So what we do is, if we put a third dimension in here, it now pops out in that direction, and so now it'll reach that outer wall. And if it's towards the back, that third dimension will still allow it to reach that back wall. So the JL4 is, because it has that long head, will scrape the front wall and will hit, you know, anything anterior and posterior. But the JR4, because it has that tertiary curve, as we turn it, it won't hit that anterior wall. The tertiary curve will prohibit from doing so. So if we have a little bit of a third-degree curve on here, all of a sudden, whoops, it's off that posterior wall. It's off that posterior wall and is now aiming at that anterior wall. Okay? So we need to have that third dimension curve on there to allow it to do that. So it's good for anterior and posterior takeoffs. That was and to tell you that was you won't appreciate it because you all have the 3DR curves now. And if a doctor has an anterior or posterior takeoff ostium, the doctor will say, grab me a 3DR. Before we had 3DRs, getting an anterior or a posterior ostium on the right side was nearly impossible. We had to try to use amplats lefts. We had to try, sometimes we'd use a JL4 to try to get into it because no catheter was designed, no catheter had that third dimension. And so when Dr. Williams designed his, the 3DR, it was actually able to create a catheter with that third dimension to it. Really changed our ability to get those ostiums. So when that came out, we were all like, this is a miracle, it's beautiful, crying, you know, underneath our masks, because it would take a 2-hour case and put it down to 30 minutes. So it was a really cool thing. Now, my favorite catheter, which you will never see used, and I'm telling you this right now, I bet you could go into a cath lab right now and ask them for this catheter and they will have no clue what you're talking about. It's one of my favorite catheters. It's great in certain circumstances. It's called the Arani. And there's two types. There's the Arani 90 and the Arani, actually that should be 75. Arani 90 or the Arani 75. And that degree is referring to this curve right here. So the Arani has these dramatic dynamic curves. It has the proximal curve here, the tertiary curve here, and excuse me, the secondary curve here and the tertiary curve here. And the 70 degree or 90 degree is the angle of that secondary curve. So a 90 degree Arani would come off like that, okay? So the Arani, I drew it up here so you can see what this catheter is meant to do. It's meant to go over, hit that part of the aorta, bounce off, hit this part of the aorta, bounce off, and dive into the ostium. So, what is the backup like on this thing?
Great.
This catheter, once it's in place, will not move. What is the stability like?
Great.
Great, because that primary curve, pushes it really, not too deep, it's not going to deep seat, but it pushes it into the artery. Oh, it's a beautiful catheter to see used. Nobody uses it. And I've seen a doctor try to use it, and as much as I love how it's designed to fit into the aorta, as much as I love that, no doctor utilizes it. Can anyone guess why?
It's too drastic.
Yeah, it's too drastic, and to get that to take that shape perfectly, because remember, it's straight when you put the wire in, and then when you take the wire out, it has to have these drastic curves that pop into place, and it just boom, pops in. And if you're not,
take the wire in with it for a long
yep.
period of time.
And if you're not lined up right with that, let's say my ostium is down here and I just missed it by a millimeter, I don't want to, unlike other catheters, I don't want to scrape this catheter up and down without it being a wire in it, because how many times am I scraping the aorta if I do that? Three times. So there'd be 3 different places where I'm trying to find that ostium going up and down that aorta. Once it's in place, you ain't moving this bad thing. It's in place. It will not back up. It will not pop out. That thing is in there for the duration of the procedure. It is beautiful. If you have a catheter that keeps popping out and keep losing its place, and the doctor inflates the balloon and everything pushes out and the balloon slides out and the doctor's cursing, and you can say, hey, want to try an Arani? And they would almost always say, no, I don't want an Arani here. An Arani is just a mess waiting to happen.
Well, when you pull it out too, doesn't it?
You have to, again, just like with the Amplats, right? You have to push in, put the wire in, straighten everything out. So it's very hard to position and it's very hard to get out. So most doctors are like, I will struggle.
It's too risky.
Yeah, I will struggle with something else rather than deal with an Arani. So we have, and there's more than these. These are kind of like the 7 big ones. 1, 2, 3, 4, 5 are the most commonly used. I will number these again. So 1, this is what we start off with. 2, 3, 4. These 5 are the ones that you're going to see used the most. The Judkins right, always start off with that. Amplats right, the next most common. Progressive right, if the doctor is feeling lazy and it doesn't think it's a right. Coronary that's blocked. For interventions, the XBR, and for the anterior takeoffs, the William Wright. So those 5 are the ones that you're going to most often see.
Oh, for the William Wright, what are the sizes?
That's just it. It's just Williams Wright 3DR. It's one size fits nobody. Okay. So these 5, 1, 2, 3, 4, 5 are the most commonly used. Hockey stick rarely gets used. Aranis will never get used. There's others out there that are even stranger than the Arani, which don't get used very often. But you always will have more catheters for the right side than the left because it's harder to get the catheter to form properly due to the curve of the aorta. Okay. Last thing I want to talk about before I let you go today is this needle here. Okay. I just wanted you to see this. This is an arteriotomy needle. And if you look at my arteriotomy needle, your octopus is dying there. Okay. They're the same size, right?
Yeah.
Okay. The hubs are pretty much the same, except this one has what on it? What do we call these things?
Wings.
Butterfly.
Wings. It has butterfly wings or wings. That's right. Okay. But these are not the same needles. What type of needle have we been using so far? What is this type of needle called? What type of arteriotomy needle? Is that?
Like the size or?
Well, no, not the type, not the gauge, not the size, the type of arteriotomy needle. We talked about there's two types.
Seldinger?
This
The
isn't a
modified
Seldinger.
Seldinger.
Ephemeral?
This is a modified Seldinger, also known as a front wall needle. And how do I know it's a front wall needle?
Because it has that bevel angled.
It has a beveled angle and it is
Doesn't
only
have the,
The thing inside.
the
the
thing
thingy,
inside it.
right.
That's right. It's a one-piece needle, right? It has nothing to do with the, whoops. It has nothing to do with the butterfly wings. That doesn't change it. But this is a one-piece needle. There's nothing inside of it. However, if you look at this needle, this is a true Seldinger needle, also known as a thin-walled needle. It has the needle portion and an obturator. The obturator is what goes down to the center. And remember how this works? Is we plunge this down. Be careful so I don't stab myself. Oh, I got that one all right. Okay. Plunge it down, take out the obturator, and pull this up until I see a blood flash. And the reason this is beneficial is because as I'm plunging the needle down, it could fill in
it's fat.
with fat or tissue. And with this needle, I would never know it. I could go all the way through and like, why am I not bleeding? Well, tissue could build up in this, which is why when the doctor takes out this needle, you should flush through it to see, was it blocked? Whereas with this needle, because there's that centerpiece in here, I go all the way down. It's blocked, so blood can't come out. Okay? So you see that? There's no lumen. I go all the way down, take out the obturator, and now I will get a blood flash as I pull out. And this way I know how many times did I stick that artery? Once. Whereas with the front wall needle, the doctor's trying to stick it through that front wall and try to only stick it once, but if this fills with tissue, he might hit it and not realize it. Might hit it again, not realize it. Hit it again, not realize it. Take it out, you flush it out, this piece of tissue comes out, and you're like, how many times did I hit that artery?
3 times.
2, 3. Maybe I went through and through. Maybe it's 6. Maybe I went through and through twice. I have 6 holes in this little artery. I don't know it. So that's the downside of the front wall needle. But this is, I wanted you to see what a true Seldinger or what we call thin wall
So
needle
the
look like. Obturator?
Yeah, is that pointed too?
Yep. That's the part that's pointed.
Okay.
Because it
so
acts
then
kind of
it
like a
will-
dilator. So once this comes out, it's just a blunt.
Okay, so then it doesn't have a bevel or
Nope.
anything.
No, it's just blunt. So when I get into the artery, I know it just will bleed.
Yeah.
So
And, it's usually always longer than
the bevel has to be, yep,
Yeah.
because that's the sticky part.
right.
That's the stabby part. So we go in all the way, take out, and I know if I have a blood flash, I'm in the artery. If I have no blood flash at all as I pull out, I was never in the artery. And in that way, I only stick the artery once.
This is the one that's usually used for
The radial artery, yep. And we'll explain why that is later. So that is what the true Seldinger or thin wall needle looks like.
Are they those colors every time?
This is 18 gauge,
Pink.
pink.
Always using the obturator has the pink.
No,
Okay.
it depends on what the gauge is.
Okay.
No, you just have to know, is there 1 pieces or 2 pieces? If it's 2 pieces, it's a thin-walled Seldinger needle. If it's one piece. It is a
Modified.
single or front wall modified cylinder needle.
Always have
But
the
it-
wings.
Nope.
This could also have a wings, right?
Yep. They can have wings. They cannot have wings. Whatever they want to purchase, whatever they feel more comfortable with. Wings or no wings. Okay. That's enough for today. On Thursday, we're going to do right coronaries and left coronaries, see how the catheters work. We're getting ready to do an entire procedure together, start to finish. So that's what we're working on. So I will see you all on Wednesday.
No assignments, Rob?
No assignments this time.
Perfect.
No assignments this time.